prediction and prevention now of fetal growth restriction is similar to that of preeclampsia. Combined screening at 12 weeks, history, mean arterial pressure uterine because of units, placental growth after the followed by aspirin and or heparin, and then reassessment at 22 weeks, separation of the population into a lower risk group where it may not be necessary to do anything anymore, a moderate risk group where they need to be reassessed, have a scan at around 36 weeks, and the more high risk group where they need to be reassessed at around 32 weeks. I thank you for your attention, and I have proposed a new approach in pregnancy management in the context of preeclampsia and fetal growth restriction that inverts the traditional pyramid of care of examining women, measuring the blood pressure, and palpating the abdomen every 4 weeks until 28, every 2 weeks until 36, and every 1 week until delivery, with a new scheme of high-level assessment at 12 weeks, with the aim of prevention, and then reassessment at 22 and 36 weeks, with the aim of diagnosis and planning of the best placed method of delivery. Thank you.
Professor, can you hear us? Can you hear us from Professor?
Yes, I can hear you.
Can we just ask a few questions, if you don't mind, just for a few minutes? Any questions, please?
Thank you very much for, as usual, excellent presentation. Abu from the Cairo Fetal Medicine Unit. I'm asking about the injectable antithrombin therapy. The Cairo...
The system are talking too much, and I cannot hear. I cannot hear anything because the technicians are talking to their mother.
Thank you very much, Professor, for the excellent presentation. I'm Abu from the Cairo Fetal Medicine Unit. I have a question about antithrombotic therapy, by injections like heparin. Do we have any evidence, like the aspirin we have? There's a lot of use of heparin now, but do we actually have sufficient evidence to start early on in patients with high risk instead of aspirin?
Thank you. If I understand your question correctly, is what is the evidence in relation to the use of heparin in these pregnancies? And I just want to show you this slide. The study, a meta-analysis by Dot in 2010 that analyzes. I am afraid that your technicians are not allowing me to speak, and it's very, very irritating and exhausting to me to be giving a lecture and to hear them talk to their mothers or to each other. If somebody can please tell them,
I did.
Let this stop. I am not going to give any lectures. It is very, very tiring. Then I will stop.
No, we apologize for that, Professor. We apologize for that. They were just fixing something with the sound. We apologize for that.
There are 7 trials involving 710 patients where they have given antithrombotic medication, and they have shown in the context of recurrent severe fetal growth restriction that we can reduce the prevalence by about 60%. These are cases where the women that we are investigating as to whether the prophylactic use of clepsane is useful. It is in our center that will only be used again if the mother is found to have autoimmune disease.
Okay. Thank you, Professor. We asked that because we have a very high rate of abuse of using heparin for all pregnant women. So that's a very clear point that we just want to stress on only in women who have autoimmune disease. Any further questions, please?
Thank you.
Shema will be testing again at 10 minutes to 11, please, your local card.
Thank you so much for your interest and it's time for paying. Thank you so much.
Shema, can you hear me? Shema, can you hear me? Hello, Shema. Can you hear me?